Hello and welcome to the webinar. Karina is the Professional Advisor for Children and Young People for the College of Occupational Therapists and a Senior Lecturer in Occupational Therapy at Canterbury Christ Church University. Her background is working with children with specific learning difficulties and school-based occupational therapy practice. Karina's PhD research interests are in occupational therapy student learning processes and occupation-centred occupational therapy practice with children. So now over to you, Karina.
Thank you, Claire. I can hear the background noise on the line.
Yes. Let me just sort out. Sorry, everyone, for that. There you go.
Okay.
Sorry about that.
Brilliant. Hi, welcome everyone to the webinar. I'm going to be talking for the next half an hour, 45 minutes or so, just about some of the experiences that we've had writing outcomes for health, education, health and care plans. As Claire mentioned, I am an occupational therapist myself. I'm a professional advisor at the College of Occupational Therapists. So I've had the opportunity to meet with and discuss these education, health and care plans with a variety of occupational therapists who are implementing them across England. And I've also had the opportunity to spend some time with those in government and those in areas where they're implementing these issues and looking at it kind of from a broader perspective. So the session today, we're going to be talking through, and I'm just trying to, oh, there we go. So the overview of the session today is I'm just going to mention some of the key points about the legislative changes. It's not going to be a comprehensive recap of them, but just kind of highlight a few things that I think it's important to keep in mind when we're undertaking these education, health and care plan processes. I'll briefly cover what the sections are within the education, health and care plans, because they have changed from the statementing process. So we'll cover the broad aspects of what should be included in each one of those sections. I'm then going to go through what is an aspiration and need and outcome and provision, which is how these education, health and care plans are written. And there will be a short quiz for you all so that we can see, trying to get a bit of clarity as to those terms and exactly what they're needing and what they're meaning. We'll then cover the importance of the person-centered approach, which I think is very in line with occupational therapy theory and our profession as a whole. And then start to talk about where to start with some of the writing of aspirations, needs, outcomes, and the provision. I'm going to finish off by briefly talking about some of the timeframes and timescales for education, health and care plan advice. And I will say up front that there still is a bit of uncertainty about some of this information, because some of it will need to be tested in order to clarify the legal perspective and the legal stance. The final slide's got some additional resources, and then I think we'll hopefully have some time for questions at the end. So just to start off with, talking about the key points about the legislative changes. One of the key features of the new SEN reforms, SEND reforms, is the involvement of children, young people and parents. And this is very much key and central to all aspects of the process. So there is a lot of emphasis which is placed on gathering the opinions and being guided by the children, young people and families about the whole special educational needs provision and the process. The legislation now is applicable to all state-funded schools and colleges, so that is a bit of a change from the previous legislation. It's been expanded. The key focus is around coordinated assessment, and there is a lot in the legislation about cooperation between education, health and social care services in order to implement these EHCPs. And the provision is from 0 to 25 years, so it has been expanded in the upper range, so now it goes into up to 25 years. There is a responsibility for local authorities and health and social care to commission services jointly, so it should be coming out of pooled budgets. And I know that a number of areas are at different stages of that process. That process needs to be evident on their website, so if they need to be talking about what is in their local offer for services, and that needs to be clear and transparent, and also done in collaboration with the children, young people and families as well. There is a bit of there is more of an emphasis on the transition planning, so a focus on preparing for adulthood. So there are transition aspects to the legislation which is transitioning out of education into further education, higher education, employment, and also transition between services as well. So there's a real focus on that. There is an option of a personal budget which allows families to have more choice and control over their services, and I think some of the provisions at the moment are just being sorted out locally with who is supplying those personal budgets, how are they managing those different budgets, and I think different areas have different requirements around those personal budgets, but the idea is that there is more choice and control for children, young people and families. And as of the 1st of April, this will apply to children and young people detained in youth custody. So there is also provision for education, health and care plans and special educational needs support while children and young people are in detention as well. So this slide is showing some of the sections that the Education, Health and Care Plan needs to cover. And as you can see, it's changed from Part 1, 2, 3, etc., which was in the statement, and it's now sections A to K. So the first section is about the views, interests and aspirations of the child or young person and their parents or their family. So this is really setting the tone of the entire EHCP. So what is it that's important to young people and families? Where do they see themselves in the future? What do they want to aim for in the longer term? So that covers Section A. Sections B, C and D, they are all related to the child or young person's special educational needs or health needs or social care needs. So each one of those sections is talking about the needs of the child or young person in relation to those three areas. In order to get an education, health and care plan, the child or young person does need to have a special educational need. So that kind of is the trigger for getting one of these plans in place. But once the plan has been triggered, then actually it should cover more than just the educational aspect. It's covering the health and the social care needs as well to be a more coordinated and joined up approach to supporting the child, young person and family. Section E is talking about the outcomes for the child or young person, and that's about what is it that they want to achieve and how, like, it kind of sets the tone of where services are going to be focused and what it is that the services are going to work towards is in those outcomes. Sections F, G and H, they relate to the provision that's needed for the young person to meet those particular outcomes. So if the child or young person has a special educational need and it's in Part B, then it will automatically relate to Section F around what is the provision for that child in terms of their education. Likewise, health and social care needs. Section I is about the placement, so the school placement or college placement or wherever the placement is going to be set out for the child or young person. Section J is around the personal budgets, and Section K is additional information and advice. So that's just providing an overview of what the sections are to be included in the education, health and care plans, and bearing in mind that it will be occupational therapists, but also other health professionals, physios, speech and language therapists, educational psychologists, all of those people involved will be contributing, along with the medics and along with the educational staff as well, so SENCOs and special and teachers, and so everybody is going to be feeding into this one plan. So when we're starting to talk about what is a need, what is a provision, and what is an outcome and an aspiration, those terms, I think they have different meanings to different people. So there is a bit of confusion about them. So we're going to just go through a very quick quiz to test your own knowledge about these. So perhaps you can get a piece of paper and a pen and maybe just note down your responses to these following questions. So the first one is, what is an aspiration? So is it an ambition or hope? Is it a dream? Is it breathing in a foreign object? Is it the same as an outcome? Is it all of the above or none of the above? So just have a think about which one you think it is. Okay. So an aspiration, it's an ambition or a hope. So it's something that is hoped for within the future. So let's have a look at the next one. What is a need? So is a need cerebral palsy? Is it an adapted chair? Is it a step in baking bread? Is it self-care, unable to dress independently? Is it all of the above, or is it none of the above? So again, maybe just jot down what you think a need is. So if you said a need is self-care, unable to dress yourself independently, you're correct. It is also a step in making bread, but probably not spelt that way. So a need, it relates to how the child or young person, what is it that they are having trouble with, what is it that they're unable to do, what is it that specifically that they need input from a health, social care or educational professional. It might be that cerebral palsy means that the child is unable to dress themselves independently, but just because you have cerebral palsy doesn't mean that you have a standard set of needs related to that, because obviously every child, young person is different, and you have different skills and abilities depending on the environment that you're in and the task that you're being asked to do as well. So likewise, an adapted chair is not a need, that's a provision. It's something that an occupational therapist might provide in order to support a young person, but that's not really a need in itself. Okay, so let's have a look at an outcome. So what is an outcome? So a task an occupational therapist will do, such as supplying equipment, a task an individual will do, such as attending a handwriting group, the benefit or difference made to an individual as a result of a change. Is it all of the above or none of the above? So maybe just jot down what you think there. Okay. So if you said it was the benefit or difference made to an individual as a result of a change, you'd be right. So when we're talking about an outcome, it is what do we want, what do we hope, what do we want the person to be able to do as a result of our intervention? So what is it that we will see that is different? It's not about how we will get there. So it's not about supplying equipment or attending a handwriting group. It's about what will be the result of attending a handwriting group or supplying equipment. What is the end point? for that. So that's what we're talking about when we're talking about an outcome. And finally, what is provision? So this is just a true or false question. So is it the action of providing or supplying a service or resource? So make your decision. And that one's true. So the action of providing or supplying a service or resource. So that's actually what the occupational therapist would do, or what the teacher will do, or what the physiotherapist would do. That could be in terms of providing a program, or working with them one-to-one, or giving some educational advice, or providing them with a chair, or sloped writing surface, or anything like that. So it's about what will the therapist do, what will the provision be in order for that child or young person to meet their outcomes. So just to recap on all of those, can you pick which is which? So have a look, there's 4 statements there, and one of them is an aspiration, one of them is a need, one is an outcome, and one is provision. So have a read through and see if you can pick which is which. So to independently move around the school by the time I will transition to secondary school. 4 visits from an occupational therapist in the next 9 months to develop organisational and navigation skills. I want to live independently and get a good job designing computer games. And moving around the school, unable to organise belongings and get to class on time. Okay, so hopefully you have tried to link the statement with the heading, and if you got it in this order, then you're correct. So the aspiration is about living independently and designing computer games. That's the hope, or that's the ambition. The need is moving around the school, that they're unable to organise their belongings and get into class on time. So that's what it is that is causing them challenges to them being able to participate in the school environment at the moment. The outcome is to independently move around the school by the time I transition to secondary school. And the provision is the 4 visits from the occupational therapist to develop these kinds of skills. So one of the key factors here is that there should be some consistency between the aspiration, need, outcome and provision. So in order to work towards living independently, which may or may not be realistic, but to work towards that and get a good job, this young person needs to be able to move around the school. So that is the need at the moment. So we've broken down the aspiration into one step of that. And then the need, outcome and provision all relate to the same factor. So it's all about moving around the school. So that's the need, that's how we want the outcome to be, and the provision is related to how we get there. So there needs to be consistency between those aspects. Okay, so that's an overview of some of the factors which are going to be included in the Education, Health and Care Plan. I guess one of the overarching aims, and this is within the legislation and also within what we're expected to do when we're creating these, is around a person-centred approach. So this is really quite familiar for occupational therapists. So I think we are ahead of the game in terms of understanding what this actually means. So just to recap briefly, it's putting the child and young person and family's views at the heart of the education, health and care planning process. And that sometimes can be easier said than done, particularly if service requirements dictate that we're only able to do a certain amount of service, or we're only able to assess within a certain time frame, or there's waiting lists or other pressures. So that's always going to be a complexity within this, but the intention within the legislation is that the child, young person and family's views are at the heart of this process. So this is about balancing what's important to the child to lead a fulfilling life with what's important for the child or young person. So it might be that the child or young person is desperate to play football, and that is what they want to focus all of their effort and energy and therapy towards playing football. But it might also be that the child or young person needs to have be able to access the curriculum and actually do some writing and drawing and participate in the classroom. So those things need to be balanced, but they do need to be taken into perspective. So it's not one is more important than the other. It's about that negotiation between what's important for the child or young person and what it is that is important for them as well. Okay. So just talking about where to start with this whole process, it can be a straightforward process, or it might actually seem quite complex to begin with, but I think once you get your head around what's expected, it does actually make some kind of sense, which is helpful. So let's just start with the aspirations in more detail. So the aspirations are the views and aspirations of the child or young person, and these should be made available from the local authority requesting the occupational therapy advice. Now, I understand sometimes this isn't happening, and that can mean that actually the children and young people or parents are having to retell their story to each professional. But actually the intention, and it's quite clear in the legislation, that we should avoid the families and children having to retell their story. So that information about the aspiration, views and background information should be made available when the occupational therapy advice is requested. I think occupational therapists are very good at trying to determine what the aspirations are, and it's probably quite important that if there is capacity for the occupational therapist to actually work with whoever it is identified within the local authority who is making the request, to help support them to get that information from the child, young person and family. Because I guess you can appreciate that if somebody was to come to you and say, so what do you want for your child for their future, it's a very big question, and it will take some facilitating in order to get a reasonable and useful answer. So if the family, if the child, if they want to be a professional footballer, for example, and this was an example given to me by some of the occupational therapists recently, is they worked through with a child with quite significant cerebral palsy, and they thought they were at a point where the young person was in agreement with them that this was going to be a lifelong condition and it might limit his opportunities with certain things. When it came to the aspirations, he was adamant that he wanted to play professional football. And so that was what was written in his education, health and care plan, and that is perfectly acceptable, because these aspirations, they don't need to be realistic, and actually I don't think it's the role of the occupational therapist to squash somebody's dream about what is realistic or not. We don't have a crystal ball, we don't know what's going to happen, and I think it's important for us to support people in their ambitions and aspirations. So these aspirations, they don't have any legal teeth, So nobody's going to come back and say, but I'm not a professional footballer, and you said that I was going to be a professional footballer, so therefore I'm going to sue you. So that's not going to happen with aspirations. But it does give us an indication of what is motivating for the child, young person, and what's motivating for the family. So for example, if the family really wants their child to be living independently at some point in the future, then that's going to give us a good indication of some of the things that we're going to be working towards around independence in order to meet that overall aspiration. Okay. So just some examples of aspirations, and these are just very short little clips, but there is a whole section that would be covered within the EHCP. Things like I want to go to university, I want to live independently, I want to be in a relationship, I want to be a marine biologist, I want to get a job. So a lot of these aspirations would be what we would expect for any child or young person and family. So we would obviously need to find out what are specifics for individual families, but in general they're going to cover these kinds of broad topics about how they want to live, if they want a relationship, if they want a job, if they want a further education, so those kinds of things which are common to most children, young people and families. Okay, so once we've got an indication of what the aspirations are, we can then focus on what are the needs for the child or young person. And I would say that for occupational therapists, these need to be written as occupational needs. So what is it in terms of the needs of them undertaking, engaging, performing their occupations, which are impacting on their overall ability to engage in what they're doing. This could be different for other professionals. They will write the needs in a different way, but I think definitely for occupational therapists that in order to remain having occupation as our core focus, we should be talking about occupational needs. So the focus on the needs is about the priority occupations only. So if we have an idea from the family and from the young person about their aspirations, we should be able to focus on what are the key areas which are the priority for them at the moment. And these are going to change as the child gets older and as the situation and circumstances change. But we really should be just looking at the priority occupations rather than trying to give a comprehensive picture of every aspect of the child or young person's life. That's not really the focus of the education, health and care plans. So we're not providing a overall occupational therapy assessment. We're focusing just on the priorities. And when we consider how we're writing the priority occupations, I think it's really important for us to be mindful of the language that we use. Because I have known many parents have become quite distressed and distraught about how some things are phrased within a report. Many families know that their child has some significant issues, but when it's written down in a way that's, for example, Miller was unable to walk, she had extremely poor fine motor skills, which means that it impacts on all areas of her schooling, it's quite abrupt and quite harsh. And it doesn't support the child, young person, or family to have it written in such a harsh manner. Also, when we're writing these needs, I think we need to be more specific with what we're meaning. So, yes, a child might have poor fine motor skills, but what does that actually mean for the occupations that they're participating in? I have known some children who have very poor fine motor skills, but they're still able to do a lot of things because they found other ways around doing it, or they're particularly motivated to do something. So it's not only related to the child's skill level that's going to impact on how they're going to be doing their occupations. So you could write it talking about what are the occupational areas. So for example, moving around the classroom might be one of the areas that's problematic for Miller. And you could write something like, she is unable to propel her own wheelchair, she required assistance from the teaching assistant to move her wheelchair and position her at the desk. So that really highlights and paints a picture of exactly what it was that was causing the problems for Miller, in the fact that she was unable to walk. She was also unable to propel her own wheelchair, and she required that assistance to maneuver around the classroom. So it gives us a really specific focus and an understanding of actually how do her skills impact on what's happening in the classroom. Likewise, you could talk about drawing and writing in class. So Miller is unable to open the clip on her clipboard and slide her paper. She needed assistance from the teaching assistant to perform these task actions. So again, it's acknowledging that she does have some fine motor skills issues, but it's being quite specific about how is that impacting on the occupations. And I think if we're writing needs in this way, it still gives us the information about what the performance challenges are, but I think it's more meaningful for people who are reading it who are perhaps not occupational therapists. So when you're thinking about writing these needs, we've developed just some examples of things that you might like to consider, so some example occupations. And these are by no means a comprehensive list. It's just a starting point that you might want to think about in terms of what the children are doing in the classroom, or what some of the needs might be. So there are examples of packing up and tidying up a desk. Is that where the issues around mobility or fine motor skills, is that where it's impacting most? Or is it is a priority for the child or young person and the family about going to the toilet or getting changed for sport? Or what is it that's actually the priority for them at the moment? And we know that a lot of the children that we see are going to have a lot of areas that they have needs in. But it is, I think, quite unrealistic to expect that we're going to have lots and lots of areas that we can work on simultaneously, because it's going to be overwhelming for the child, young person, and also for the school setting and the parents. And I think it's more important to focus on a few key areas and do them well and get results from them, rather than try and suggest interventions that are intended to support every area of the child's development, because I think that it can get lost then. So there's a few example occupations for in an educational setting. There is also some example occupations in a home setting, and again, might be doing homework, washing dishes, doing chores, going out, brushing your teeth. Might be sexual awareness and sexual activity, playing sport. So there are a number of things that might be considered more localized to home occupations. And we've got some community occupations there as well, so public transport, or going out to the cinema, or playing sport, or going on holidays, on a date. So these are just example areas of what you might like to think about when you're considering what to put in the education, health and care plans. And I would suggest that those occupations which are occurring within the school situation, you're more likely to be able to fit them into that Part B, Section B of the Education, Health and Care Plan around the educational needs, because it appears that they clearly relate to the educational provision. Whereas the home and community occupations, it might be a split between the health and the social care sections, which is C and D. So that's by no means rigid, that there is flexibility within that, but it just might be important for you to consider where you want to put your occupational therapy needs and subsequent provision. there is funding implications for which section you decide to put things in. So just like it was with the statement, if you put something in section B, educational provision, then it needs to be education's responsibility to provide it in section F. But if it's in the other two sections, the health or social care needs, then there are different requirements for who's responsible for those aspects. So it's just something to bear in mind. Now, I have come across a number of areas where they have already developed a template for education, health and care plans, and the template comes with these following sections, so these headings around communication and interaction, cognition and learning, sensory and or physical, social, emotional and mental health, or behaviour. Now, these, I can understand why these headings are used, because we're trying to get a common language across with the physios, speech and language therapists, and with other professionals. So I can see why they could be useful, but I guess as occupational therapists, because we're looking at the occupational needs of a child or young person, they could span a number of these different categories. So we are in a bit of a difficult situation if we're trying to remain focused on occupation but still having to fit in with what is quite a medical reductionistic template. So I would say if you are required to use these headings, then I would suggest that you still focus on the occupational needs, but when you're thinking about what is the primary reason for the problems with these occupational needs, is it because of their communication and interaction skills, or cognition and learning, or sensory and physical? And whatever you think, whatever you've judged as the primary need, the primary sorry, wrong word, the primary reason for these issues, then you would put that occupation under that particular heading. It is a bit messy, but I guess it's trying to fit in two different perspectives. And I think the danger is if we just use these headings, we might be going back to explaining how poor the fine motor skills are, or how poorly behaved the child is, or things like that. And I guess we're trying to make sure that we are accurately stating what we want to say, but not creating a really dismal picture for the child, young person and family to be reading. So just to give you an example of what I mean by that, so when we talk about the same child, Miller, in the example that I gave, I judged that her needs were primarily related to the sensory and physical needs for this occupation. So in the report, I would have put these two areas under a heading sensory and or physical. So, but I still would have used moving around the classroom, and that she's unable to propel her wheelchair, she required assistance, and the drawing and writing, she's not able to open the clip. So those things I judged were as a result of a motor difficulty, that she wasn't able to do those tasks. So that's why I put it under the sensory and or physical. If, however, I felt that the primary issue was relating to maybe cognition and learning, then I would have put it under that heading, but my example would have been different. So, for example, a writing and drawing one, Miller looked away from her writing frequently, which interrupted the completion of her task, and several times Miller needed help from the teaching assistant to keep her focused on the task. So the issue that she had with drawing and writing was actually different. It was more about her focusing on the task or being distracted by things that were happening in the rest of the classroom. So if that was the case, then I would have put the writing and drawing under the heading of cognition and learning, because I thought that was the primary reason for her needs. Okay, so let's just talk now about writing the outcomes. So the definition of the outcomes in the SEN reforms relates to the benefit or difference made to an individual as a result of an intervention. It should be personal and not expressed from a service perspective. So that's actually the definition within the legislation. So we're talking about what is it that we will see as a difference, or what is the benefit of what the intervention we're proposing. So it's going to relate directly to the needs. So in Miller's case, we talked about her drawing and writing, so therefore the outcomes would relate to drawing and writing or moving around the classroom, because those are the areas that we expressed were the needs. So there should be some consistency and some logic between the needs and the outcome. Some key phrases you might use to get you started. So by the time I'm in this particular class, or by the time I'm this particular age, or whatever, I am able to do or maintain whatever it is that you think that they're going to be able to do. So you want to think about what would success look like. So you might use questions with the family around, so if you woke up tomorrow morning and things were different, what would that look like? What would change? What would be different? So you're focusing on what would success look like, and then how will you know that it's been achieved. So this really does need to be written in a way, perhaps you could use the SMART goals or SMART outcomes, so specific, measurable, achievable, realistic, and time set. So if I just give you some examples of outcomes. When in the legislation, when they're talking about outcomes, they're talking about perhaps the end of a key stage, or perhaps in 2 to 3 years' time. So it's looking quite long term in terms of these types of outcomes. So might be by the end of year 11, I can read and understand Harry Potter and similar stories. Or by the end of the autumn term of year 7, at secondary mainstream school, I'm holding simple conversations with my friends in the playground. So it's about what would it look like if things were successful. What is the outcome? What is it that the person will actually be able to do? So that's written from a first-person perspective, from the child or young person, and that could be completely appropriate for how you're writing in the plan. You may also want to put it in from the third-person perspective. So, for example, for Tom to manage his school routine of finding his way around the school and managing his self-care independently by the end of year 10. So those are measurable, but they are quite big. So I would suggest that actually we need to have some steps towards those outcomes. And in the examples that I've given, the steps towards the outcomes are kind of within the 12 months of the report. So each of the education, health and care plans should be reviewed at least every 12 months. So it's what is expected within that year, although you might decide that you're going to break that down into smaller targets. So, for example, a step towards the outcome might be finding his way around the school, so Tom will find his own way to his classrooms by October, or Tom will change for sport by November. So those are the things that are going to be steps towards his major outcome of managing his school routine and finding his way around the school. So in terms of finalising how will this be achieved, this is where we talk about provision. And when we're talking about provision, I've divided this up into the indicative actions, so what will be done and who will do it, and also the resources, including frequency. So we do have to be rather specific when we're talking about what it is that the occupational therapist will do in order to achieve that, that outcome. and that step towards the outcome and the outcome. Now, it could be actually that it's not just the occupational therapist who's involved with these particular outcomes and steps towards the outcomes, and I would say that that should be encouraged. So, for example, if a speech and language therapist was also involved, or if a physiotherapist was also involved with Tom, they might have targets which are talking about the changing for sport as well. So they might have physical targets that would come in under this particular provision. So this is where it is ideal if people are talking together, so that this kind of outcome, steps towards the outcomes, and who will do it and the resources can be discussed, negotiated and coordinated together, so that we're not duplicating services and we're also not having far too many outcomes or steps towards those outcomes that it's just overwhelming for the child, young person and family, and also the education staff. So I think we're actually quite skilled at talking about what we're going to do and the resources that we're going to need. And the feedback, some feedback that I've had so far is that when the report is written in a way like this, it actually is supported by the educational, by the local education authority, and also more likely to be upheld if it does go to tribunal, because it does really very much link to what it is required in the legislation, and also how does occupational therapy fit within educational provision. So this is, obviously there are room for improvement, and I would say that this is an ongoing resource and an ongoing development. But early indications are seeing that we've had some positive responses from writing things in this way. So just to finalise, I will just talk quickly about timeframes. Now, ideally, the advice or reports used should not be more than 12 months old. So if you've seen a child and it's under 12 months and the request comes through, then you should be able to use that information for the EHCP, providing it's acceptable to the parents and the child or young person in the school. So providing things haven't changed so much that you're needing a new information. But local authorities shouldn't seek a new assessment. It's advice based on what you know of the child or young person. So if a request has been made for a child who is known to occupational therapy service, then advice does need to be given within 6 weeks. So this is a legislative requirement. The whole education, health and care plan needs to be done from start to finish in 20 weeks, and there is a 6-week time limit for getting this advice from occupational therapy. So once the request has been made, then it's within 6 weeks it needs to be back with them. There is still a little bit of uncertainty about what happens if the child is not known to occupational therapy services or they've been discharged. And I've heard a number of different responses for that, and I haven't got a clear answer as to what happens if the child is unknown to occupational therapy services. So I'm afraid I don't have clear advice that I can give on that point at the moment. And I was just thinking that if the occupational therapy reports are written with a focus on occupations and outcomes, then responding to this advice should be relatively straightforward. So just because this particular way of working is required of the education, health and care plans doesn't mean there's certain aspects that couldn't be really useful across occupational therapy services in general. So just to finish off, there's some further information. You can, we have developed an education, health and care plan template for occupational therapy advice at the College of Occupational Therapists. And if you're a member, you can access that at that first link. I think that we will probably be updating it, because as I get more information and more feedback from people using it, then I will update the information that we've got there. I've also got some more examples of those aspiration needs, outcomes and provision at that website. I understand that a lot of them are perhaps related to children who might appear more able rather than those children who are quite have severe and multiple and complex needs. I'm always looking for people to support me in developing new examples. So if anybody would like to do that, then by all means get in contact. That would be great. The Council for Disabled Children has a lot of information around the procedures, and there is the clip from Edward Timpson about the Education, Health and Care Plan. There's also some information about Ofsted and the Care Qualities Commission inspection. So this process will be inspected, and Occupational Therapy Services will be involved in that inspection process. So there's some information about that as well. There's some legal issues. There's also some information about children without education, health and care plans, and I really would encourage people not to forget that there are a lot of children who don't meet that threshold but still would really benefit from occupational therapy advice. And some information about the integration with the Care Act, and that is particularly for those young people who are in transition. And if you're wanting to go back to the actual Code of Practice and the government guidelines, then you can see that on the final link there. So thank you very much, everyone. I hope that you found that useful. I'll just leave that page up just so that you can have a little bit of a look at that. But now I guess it's open for questions. So thank you very much.
Thank you very much for that, Karina. So as you said, if anyone has any questions on the webinar panel, excuse me, on the webinar panel you should be able to see a question box. If you could type in there any questions you have, and we'll wait a couple of minutes for everyone to get typing. So there's one question that's come in already, and it's someone asking if it would be possible to obtain a copy of your presentation after this session. So I'll just start by saying we're recording this session, so we will send everyone a copy of the recording, and if Karina's happy, a copy of the slides as well.
Yes, that's fine.
Okay, thank you. So I'm just waiting a minute to see if there are any other questions that come through. Got quite a few people saying thank you very much for the presentation, so that's nice.
Oh, good. Thank you very much.
A couple of people who've put their hand up. Unfortunately, we can't do audio on this webinar, so if you can type your question, type your question in the question box, then that would be great. Okay, there's someone who said, how do we differentiate between parts F and G? That's G for golf.
Okay. So part F is looking at the special educational needs, and part G is looking at the health needs. I think that comes down to your own clinical judgment. I would say that if the need is occurring within the education setting, then there is an argument for it being an educational need. I know that there are people who have debated that, and perhaps if it's something related to the management of epilepsy, then I guess you could argue that that does need to happen in the school environment, but it wouldn't necessarily be an educational need, so that's possibly something that would need to go in the health category. So I think it's, as long as you can justify why you've put it in a particular category, and you can argue your reasons behind that, then I guess it isn't as clear cut as this is definitely an occupational, this is definitely an educational need, or this is definitely a health need.
Thank you very much for that.
I hope that's helpful.
So the next question, how do you manage outcomes for children with degenerative conditions?
Yeah, this is a really interesting question that's come up before, and I guess one of the things that I've shown on the slide is maybe around maintenance, so being able to maintain, and I think this is probably something that it would need to be discussed with the multidisciplinary team who is working with the child or young person and seeing what do you think is realistic, what would they actually like to be able to do. I mean, just because somebody's condition is deteriorating doesn't mean that they don't have some things that they want to achieve or they want to do. And it might just be that the provision is different, because you might be doing a lot more compensating in order to have that achievable, rather than having the child develop their skills in order to be able to achieve what it is that they want. So it might actually be the difference in the provision and the necessity to give additional support as the condition deteriorates. But still, I think it's important to focus on, well, what is it that they want to be able to do, and it might be related to participating in the classroom or participating in sports day or whatever. So it's how will they be able to do that given their degenerative condition.
Thank you. Someone else would like to know, what do you do if you write a report and you find that your recommendations are not incorporated into the EHC?
I would hope that I guess things might not be included for a number of different reasons, and we have to bear in mind what the process is and who is actually coordinating the reports. So if so whoever's pulling together all of the information from the different professionals, they are not likely to have a comprehensive understanding of everybody's profession-specific input. So it might be that there was a lack of clarity or a lack of understanding in what that particular provision meant, or how it fitted with the overall aims. So I guess to support that, it's trying to be clear from the outset as to how the occupational therapy involvement will address those key outcomes, so that it is more difficult for it not to be included, because it makes a lot of sense for it to be included, if that makes sense. So I think there's also a duty of cooperation, and if we can at all possible, be involved in some of those the meetings with the family and these multi-professional meetings, rather than just sending in a report. I think there is more chance that we will be able to have the discussions about what is needed and why it's needed, and make a case for that. If we're relying on our information that we provide in the written form, then we have to ensure that that's clear and comprehensive as possible, and it also can be fit easily into whatever template has been developed for that particular area. Because if it's outside that template, then it is possible that those aspects will be discarded. So yeah, no straightforward answer, but I think it's about trying to collaborate as much as you can. Although I do understand that it's quite difficult to attend lots and lots of different meetings for children.
Thank you. Can we still discharge a child before the 12-month review?
I am not sure. I would, yeah, that's not something that I have come across immediately. I'm not sure that perhaps thinking about what happened with the statementing process, I would have to look back at the legislation. I would probably suggest looking at that third link for further information, where the code of practice is, and seeing if there is some clear guidance. I haven't read anything about that, so yeah, I'm not really sure at this point.
Okay, thank you. And who do we seek aspirations from when the children are in short-term care or foster care?
I guess it would be whoever the guardian is, and also the young person, the child or young person as well. But seeking aspirations, that should be done by the local authority. So unless, I'm not sure who's asking the question, but I wouldn't expect that necessarily happens at the occupational therapy stage. That should have been taken into account by the local authority. But I would imagine that it would be the child or young person and their guardian, so whether that's the social worker or foster parents or whoever's involved.
Thank you. In our borough, we're asked to write long-term, medium and short-term goals. We're struggling with writing long-term goals for very young children. Any advice?
I guess this is probably not specific to writing education, health and care plans. It is very challenging to write longer-term goals for everyone, and I wonder whether those longer-term goals are actually bordering on the aspirations. So I would probably seek clarification as to how does the long-term goals fit in with the aspirations. I would say that the medium-term goals are probably your outcomes, and the short-term goals are your steps towards the outcomes, and perhaps your long-term goals are your aspirations. But if they've added in another step there, then I would probably go back to them and seek clarification to exactly what they're hoping for at that point.
Thank you. Is there an expected number of outcomes in each section? What would happen if there was a disagreement about priorities between, for example, education targets versus occupational performance goals?
This is where we really need to have the young person and the family at the centre of this process. So actually we shouldn't really be talking about education goals and occupational therapy goals. We should be talking about what are the priorities for the child and young person and family. And that can sometimes be quite uncomfortable for us as occupational therapists, because we're often very, very helpful in a lot of different areas. So we know that we could help in like maybe 30 different areas of this child and young person's life, and what we have to do is actually just focus on what are the priorities for the child and young person and family. There is a duty to have this collaboration and cooperation. So this is where these negotiations would happen at a meeting when you're finalising these education, health and care plans, so that you can actually have these face-to-face discussions and decide together what is the priority at a certain point in the child or young person's life. So it is all about negotiation and collaboration, really.
Thank you. What happens if your recommendations are beyond what the core offer is for the NHS service provider would usually offer?
It is very clear in the legislation that you should be recommending based on need, not on what is available. So I think you need to put in what you can justify as required for the child or young person, and not just put in what the service, what is available, which service is available. So you would write down what you believe the provision is, and it depends on which section it falls into as to how that is funded, or whether the personal budget comes into play. But yes, it's quite clear that it should be based on what is it the child needs, not what it is that the services are able to provide.
Thank you. We've got a couple more questions, if you're okay to...
Okay, I'll just take a drink of water.
Okay, thank you very much for doing this. So the next question is, if a child is known to the service for review of equipment only by OT assistance, do we need to provide a report, and who would be expected to write it? Would it be acceptable to write a short report focusing only on equipment?
I would say that if the child is known to the service, then you have a duty to provide the occupational therapy advice. And so if you don't have the required information that you need to provide that advice, then I think that you would need to make sure that you're happy with the advice that you're giving, and that the advice does cover what they're asking for. So I would hope that there is provision to be able to review, and even how you choose to review, it has to be that you're comfortable with arguing what you've done and your recommendations that you've made. So you have to make the argument that what you have done is sufficient and is the occupational therapy advice. And if you get called up to tribunal, you have to be clear that you will be arguing what you provided and that is sufficient for the occupational therapy advice. So it does come back to you as the occupational therapist to determine what level of advice you're giving and how you can justify that. And I don't think that justifying it based on, well, that's the only service that we have available, I'm not sure that that would hold up terribly well in tribunal. So yeah, just I would caution you with that.
Thank you. And final question, what would be the protocol if changes agreed at the EHC meeting are not made to the EHC plan?
Could you repeat the question?
Yeah, sure. What would be the protocol if changes agreed at the EHC meeting are not made to the EHC plan?
I guess that would depend on what changes were made and who was making them, because once the EHCP meeting has happened, then a draft report would go to the family and the child and young person and family, and they need to agree or dispute what's in there. So I guess if the family were not happy with what was actually put into the draft plan, then they do have an opportunity to dispute that, and hopefully that will then be resolved within internal processes. And if not, then there is the tribunal system that it can go forward to as well.
Great. Thank you very much. A couple more people saying thank you again for your webinar this afternoon. So there's no more questions. Thank you so much for answering all of them.
That's all right.
We'll end the webinar there. Thank you again.
Thanks very much, everyone.